इधर रखा है.
So the first talk of today's this IC is on new perimeters. So there was a lot of discussion on visual fields in the last session also, and we all are aware of the fact that it plays a crucial role in the diagnosis and the management of glaucoma, and this is achieved through standard automated perimeter or SAP. But though it is a gold standard, it has got some disadvantages in that it's not portable, needs a dedicated space, a dark room, a trained technician, and also it cannot be employed for mass screening and also for self-monitoring or home monitoring. So before we move on to the newer perimeters, let's have a look on the evolution of the HFA. A lot of changes have taken place both in the form of test strategies and test patterns. We have a HFA3 with a liquid trial lens, which instantly delivers each patient's refractive correction without the need to change the trial lenses. And in the strategy, we have the new CETA Faster, where these 7 adjustments have been made to the existing CETA Fast to improvise the test timings. Thereby, it is 30% shorter than CETA Fast and 53% shorter than CETA Standard. However, the reliability is less as compared to that of the CETA Standard. This is because of the seeding point errors, as it uses only a single staircase reversal at the cardinal points, and also it is difficult for the patient to get adjusted to this new test. Of late, there is an accumulating body of evidence to show that the central ganglion cells in the macula are supposed to be lost in the early stages of glaucoma. Hence, it becomes essential to test the central fields. As we all know, in 24-2, the points are 6 degrees away, the test points are, and we'll end up in testing only 13 points. Whereas in 10-2, we test 68 points in the central 10 degrees, and here the points are 2 degrees apart. And hence, this can pick up, 10-2 can pick up early field effects as compared to that of 24-2. However, it is not very clear whether we have to do 10-2 in every patient in addition to or instead of 24-2. So this particular study showed that 61.5% of the glaucomatous eyes were normal based on 24-2 had abnormal fields in 10-2. So to combine the advantages of 10-2 in 24-2, we have 24-2C CETA Faster. So here the blue dots indicates the points which are added to the 24-2, 10 additional points, and these are chosen from the areas which are commonly affected in glaucoma. This is how the printout looks like. Coming to the newer perimeters, we have VR-based perimetry, tablet-based perimetry, and laptop-based perimetries. Among the VR, we have C3FA, which has a virtual reality headset worn by the patient, mobile phone, on which we will be controlling the test, and the response button. All are connected with Bluetooth. So one eye is tested at a time, no need to occlude, does not need a dark room. The test results were compared with that of the SAP, and it is very useful in differentiating normals from that of the glaucoma patients. However, it did not differentiate like a mild and moderate glaucoma as compared to that of HFA, since it is a supra-threshold test. These are all various VR headsets available. IMO, this one is from Japan. Coming to the tablet-based strategies, we have a free iPad-based application, Visual Field CEC, which was tested in Nepal. And again, this is a supra-threshold test, which was used for screening, and it could differentiate normals and glaucomatous eyes. And we also have MRF or Melbourne Rapid Fields. This is an FDA-approved device, and this was also tested in Indian eyes, and it showed that compared to HFA, the mean deviation was significantly lower in the Indian population. So this is an eye catcher, which is an open source eye movement based perimetry. There is no fixation, and the stimuli is presented randomly on the screen. The perceived areas will appear as green, and the non-perceived will be red. So this has been used to triage patients, which is a busy clinic, which has a lot of new patients, where we have to filter out high-risk patients with field effects and those with false positive referrals. So this is a Moore-Fields displacement test. So this is again a supra-threshold test, and it was found to be useful in identifying glaucoma, which was defined by structural criteria. So before we move on to the other new perimeters, just few words about the ganglion cells. We have P cells, which is for color and contrast, and K cells dealing with blue-yellow response, and M cells, which is connected with temporally modulated stimuli. SWAP, once upon a time, like it was very attractive to do these tests in like patients who are glaucoma suspects or OHT, but the recent evidence has shown that SAP does much better than SWAP. That is, standard automated perimetry is better, both to identify the extent of the defect and also it can identify as early as a SWAP can identify. So this has a lot of disadvantage with the longer test duration, largely influenced by refractive error, media opacities, and hence it is no longer recommended for in the place of SAP. We can go ahead with the standard automated perimetry. We have FDT, where it is based on detection of motion and flicker. It can pick up early glaucoma. However, a progression analysis is not available here. These are all other new approaches which are coming up. This is a compass fundus perimetry where we have a fundus image on which the testing points are projected so that there is active retinal tracking compensating for eye movements, supposed to have a better spatial resolution. And this is, the printout looks what is exactly shown here. It is a fundus image, grayscale, total deviation, pattern deviation, and also glaucoma staging. This motion detection perimetry is based on the ability to detect the moving points inside this small closed circle, which is magnified and shown here. 50% of the points are moving coherently against the non-moving dots, and X is supposed to be the fixation. This is based on the M cell pathway. And we have flicker perimetry, under which we have 3 different types. This is based on the ability to detect light and dark stimulus alternations, and this is unaffected by media opacities. So next we have high pass resolution or a ring perimeter. Instead of varying the intensity or the luminance of the stimuli, here the size of the stimuli is varied. There are 14 different sizes of the rings are being used. These are concentric rings, where the edge is darker and the center is pale. This is also commercially available, but somehow this did not gain much popularity out of the country, like it's been used in only Sweden where it was made. So we have Rarebit Perimetry, which is based on identifying extremely small rare bits or microdots. So these are 24 rectangular test areas inside which the dots are projected, and the normal patient will have a hit rate closer to that of 100%. We have flicker-defined form or edge perimetry. Here we have rapidly reversing black and white dots, as shown here. At a set frequency, they are like reversed, so that the subject will perceive an illusionary edge, as shown here. So this edge perimetry is also available commercially with 10 degree, 24 degree, and 30 degree programs. So this particular study compared the white-on-white perimetry with FDT and FDF, found that FDT and FDF were better in picking up the RNFL loss, especially in early glaucomas, and recommended that these tests can be performed along with SAP. So to conclude, we have a lot of tablet-based and VR-based perimetry tests coming up, which have the advantage of being compact, comfortable, and patient-friendly. However, some of these tests are supra-threshold, though they can be used for screening, yet we have to wait for validation for mild to moderate glaucomas, and also we don't have progression analysis programs. And many other perimetries are still under the experimental stage. They need to be validated clinically, and they also need regulatory approval. In some of the perimeters, cost is also a factor. So we need to wait for a perimeter which will be applicable for mass screening, which will have a better structure and function correlation, and also which will have a dynamic testing strategies as opposed to a single test, whatever we are using now, and also the application of AI in these perimeters. Thank you.
Yeah. Thank you, Dr. Kavitha, for a wonderful and detailed